Good afternoon. Thank you, Dr. Satwan Sharma and Dr. Milind, for inviting me and asking me to deliver a talk on LPA reducing drugs. I think we have talked about the residual risk of the coronary artery disease. I think one of the factors may be responsible for the residual risk in coronary artery disease is this molecule, the lipoprotein little a, I'll call it as LPA. And there have been a tremendous amount of excitement or interest in this molecule in last decade. And this molecule has been responsible for causal association between ASCVD and calcific aortic stenosis. At the moment, there is no acceptable absolute risk for the threshold, and approximately 20 to 25% of the global population have an LPA level of more than 50 milligram deciliters. And one of this molecule remains stable throughout the individual's lifetime. So even if we measure LPA once, I think that remains stable. This is the structure of the lipoprotein little a, LPA. And it has got pathogenicity through vascular inflammation, atherogenosis, calcification, and thrombosis. I think all the factors which are responsible for atherosclerosis and coronary artery disease. This is again the molecule, and I think the most important thing for the LPA is the oxidized phospholipids, which are prothrombotic and pro-atherogenic by different mechanisms. Now, why this molecule and atherosclerosis are associated? One is there have been a lot of studies are there. I'm not going to talk many studies, but there is one Copenhagen City Heart study which showed there is a fourfold increased relative risk and a 35% higher absolute 10-year risk of MI with high LPA levels. Similarly, emerging risk factors collaboration group has also said in more than 1 lakh participants without prior CVT, there is a continuous increased risk of CAD with high LPA levels. Another from the UK Biobank study, more than 4,50,000 middle-aged individuals, they again showed a linear association of LPA and the risk of ASCVD. Similarly, the LPA has also been associated with calcific aortic stenosis. It's a strong, independent, and potential causal risk factor for aortic stenosis. More than 70,000 participants from Copenhagen City Heart Study and Copenhagen General Population Study, they showed that elevated LPA levels were positively associated with a higher risk of aortic stenosis in concentration-dependent manner with high LPA levels. The Fourier trial, which has been discussed by Dr. Samir Bhagat, more than 27,000 individuals. Again, the increasing LPA levels were associated with higher risk of subsequent aortic stenosis events either in the form of progression of aortic stenosis or need for aortic valve replacement. What is the rationale for LPA reduction? I think this is the LPA hypothesis because of there is a strong independent and causal association between elevated LPA levels and ASCVD and aortic stenosis. That's why the LPA levels should be reduced, and there is residual cardiovascular risk associated with LPA despite statin therapy, because we are using intensive statin therapy and bringing down the LPA levels to less than even 40 milligram per deciliter. Still, the residual risk remains, and that's why in such people, if the LPA levels are high, we should bring down the LPA levels to the less than 50 or less than 30 milligram deciliter to bring down the incidence of ASCVD. At the moment, there is no pharmacotherapy which is approved for specifically for lower the LPA. Dietary interventions and exercise have yielded inconsistent results. They do not affect the LPA. Statins and ezetimibe do not effectively lower LPA. Rather, paradoxically, they increase its concentration by up to 30%. Higher dose of niacin, 2 to 4 gram per day, can reduce LPA by 25 to 40%. But due to potential adverse reaction of high dose niacin, it's not a recommended therapy to lower LPA. The Fourier trial had showed the evolocumab lowered LPA by a median of 27% at 48 weeks. The Odyssey outcomes trial in more than 18,000 patients showed alirocumab and reduced LPA by 23% after 4 months. Dr. Ajit Desai has just talked about the Orient trial. The Orient 11 trial showed the inclisiran lowered LPA by 18.6% from baseline. Bempedoic acid has got no significant effect on LPA levels. One of the molecules which are again targeting the RNAs, etc., the mipomersen, can effectively reduce LPA by approximately 26%. The CETP inhibitors which came into the practice for increasing the HDL, the evacetrapib reduced LPA by 40% and anacetrapib reduced LPA by 34.1% in a small phase 2 study. But none of these therapy have been so far approved therapy for lowering the LPA. And at the moment, lipoprotein apheresis is highly effective, especially I think it has been recommended in Germany, where it transiently reduces the LPA, but it's impractical in approach. Now, I think in last decade, 2 drugs which have shown to reduce the LPA, one is olpasiran, which is a small interfering RNA, and an Ocean A dose study established ASCVD with a median baseline of LPA of 260.3 nanomoles per liter. And patient who received 75 milligram or higher every 12 weeks of olpasiran reduced 95% or greater reduction in LPA compared to placebo at 36 weeks. So it's a very effective drug. It has phase 2 studies are over. Phase 3 study, the Ocean outcome studies going on, and I think the results will be available by December 2025. The other drug, which is pelacarsen, which is an antisense oligonucleotide drug, which again showed a dose-dependent reduction in LPA up to 92%. And another trial with pelacarsen of 286 patients with established coronary artery disease, again significant reduction in LPA by approximately 80% as compared to placebo at 6 months. So these 2 drugs are there. The pelacarsen also phase 2 studies are over. The phase 3 study, the Horizon trial is going on, and the results are expected in May 2026. I think that's the for AOC 2024, what is new in 2023. These 2 drugs have come in 2023. One is the oral drug, which is movalaprin, which is an orally administered small molecule inhibitor of LPA. 114 participants and 55 were assigned to a single ascending dose of movalaprin, and 59 patients were assigned to multiple ascending dose of or placebo. They lowered LPA plasma levels within 24 hours after the first dose, and maximum reduction was 63 to 65%. So this is one oral drug which can lower the LPA. The other drug which has come again in 2023 is lepodisiran, which is again a small interfering RNA group of drug, which is an extended duration of drug, once a year injection. So this drug can be given a single dose subcutaneous, and the trial was done with placebo 4 milligram, 12 milligram, 32, 96, 304 and 608 milligram, and reduced the LPA levels up to 96 to 97% in 304 milligram and 608 milligram doses. And at day 337, the median change in LPA was 94% in 608 milligram dose group. And this drug is once a year injection, which can, like the inclisiran, which is being used every 6 months, this drug can be used once a year to reduce LPA. But this is just a phase 1 study. Phase 2, phase 3 studies will be taken up. So just to conclude, the LPA level is a well-identified risk factor for ASCVD and calcific AS, and existing lipid-modifying therapies exert modest and variable effects on the circulating LPA. The behavioral and dietary interventions are ineffective. Emerging drugs may provide effective management of LPA-mediated disease. And if these novel therapies, which I have talked about, whether it's olpasiran or pelacarsen or the 2 newer drugs like movalaprin or lepodisiran, if these drugs prove to be safe and effective, they hold the potential to have an important beneficial impact on the health of patients. Thank you.
Thank you, Dr. Gupta, for a very brief and informative presentation.